Let's talk about vascular disorders. We already talked about coronary artery disease, which is a vascular disorder, and we're going to talk about more. Okay, so coronary artery disease gets kind of put in its own special category because of the importance of supplying the myocardium with oxygen, but all the other places in our body have to be supplied with oxygen as well. So for the learning objectives, we're going to identify key vascular disorders that affect patient care, understand blood pressure classifications and their clinical significance, recognize signs and symptoms of common vascular conditions, and of course, safety considerations and appropriate precautions during physical therapy. So we're going to focus on clinical application and patient safety in the presence of vascular disorders. Hypertension, also known as high blood pressure, is defined as systolic blood pressure greater than or equal to 120 milligrams of mercury and or diastolic greater than or equal to 80. So if it's above 120 over 80, it's considered hypertension. And we'll look at the different categories of them. Hypertension is a condition that affects many people and is established risk factor for coronary artery disease, stroke, heart failure, peripheral vascular disease, kidney disease, blindness, and dementia. Awful, right? So sometimes hypertension is called the silent killer because it has no signs or symptoms until later in the disease process. And many patients do not monitor their blood pressure and are unaware of their condition. So when you have high blood pressure, it's just harder for your blood to get through the arteries, and it's hard on your heart. It's hard, lots of things can happen with high blood pressure. So these are the norms, and high blood pressure, hypertension is categorized as normal, elevated, stage 1 hypertension, stage 2 hypertension, or a hypertensive crisis. And as the name kind of implies, with a hypertensive crisis, you should be do not pass go, do not collect $200, go directly to the emergency room. So this is the classifications by the American Heart Association and the American Cardiac Council. So normal 120 and or 80, less than 120 and or less than 80 for the diastolic. Elevated is 120 to 129, so it's just like a little elevated. That can be just from exercise, systolic, but the diastolic still stays down. So elevated blood pressure is normal with exercise as long as the diastolic stays down and only the systolic goes up. And the systolic rises proportionally to VO2, the volume of oxygen. And when you get to your VO2 max, your systolic blood pressure should level out as well. So the charts match each other. Stage 1 hypertension is a systolic of between 130 to 139 milligrams mercury, or a diastolic from 80 to 89. So we're starting to get into the or. We were ands and now we're ors. Stage 2 hypertension is systolic greater than or equal to 140, or diastolic greater than or equal to 90. And a hypertensive crisis is greater than 180 and or greater than 120 dystolic. So if your dystolic blood pressure is 120 millimeters of mercury, that means that's at rest. That's when your heart is at rest. And that's a lot of pressure for being at rest. So typically the blood pressure is measured over the brachial artery, but it can be measured at the calf if there's some reason why the upper extremity is inaccessible. I have had people who even the large blood pressure cuff didn't fit over their upper arm, and so we did it on their lower arm, and that works. If you're trying to determine whether or not you have peripheral artery disease, you can take an ankle brachial index where you take the brachial blood pressure, your normal one, and then you take one at the ankle. They should be the same, so the ratio should be 1.0. If the peripheral blood pressure, the ankle blood pressure is lower, that indicates peripheral artery disease. So we want to talk about that. So the problem with hypertension is that most people don't know they have it until they do have it. So there are different kinds of hypertension. Primary is, or sometimes it's called essential hypertension. 95% of hypertension is this. So it might be due to non-specific lifestyle factors. It might be due to hereditary factors. It might be due to atherosclerosis. It might be due to high sodium diet. It might be due to physical inactivity. So if you, with primary hypertension, depending on the cause and depending on the numbers and the trends, they might treat it with just um, lifestyle modification. I mean, that might be the thing. It might be controlled through medication. So lifestyle changes are usually recommended first, and then medications recommended second. So stop smoking or using any tobacco-related products if you're currently doing so. Lose weight if necessary. Improve your diet by decreasing sodium, increasing potassium, depending on the potassium. General dietary instructions are eat more vegetables and fewer sweets and fatty foods. I think we should all do that. I think I'm going to have some zucchini from the garden. It'll be lovely. Exercise regularly, got to do that. Sleep regularly and adequately. 7.5 to 8 hours a night. And decrease your stress as much as possible. So you can't always decrease stressors, but you can decrease your reaction to those stressors. So we all have to find ways to manage our stress, and people who are in school have more stress. And so finding ways to manage your stress is a good thing. Secondary hypertension, which is about 5% of hypertension, is caused by other things like kidney disease, endocrine disorders, or medications. Birth control pills, for example, can cause blood pressure to be higher and pose more of a risk for cardiovascular disease. Hypertension management, as we said, lifestyle modifications, and if those don't work, then we have to go to medications. Frequently, people who have a high systolic but a normal diastolic, or their diastolic is just starting to creep up a little bit, they respond well to dietary modifications, lifestyle modifications. People who don't have a very high systolic but have a high diastolic, it's probably genetic and they probably need medications. So the DASH diet is a sort of, I think of it as sort of an Americanized version of the Mediterranean diet. It is, DASH stands for Dietary Activities to Stop Hypertension. And it's a very good balanced diet plan. So if people need that, like referral to a registered dietitian can be a good thing. Hypotension is low blood pressure, and that means systolic less than 90 or diastolic less than 60. It could be accompanied by symptoms of lightheadedness, dizziness, fainting, or syncope. Orthostatic hypotension, when you are sitting down, you stand up and you feel woo, dizzy. Risk factors include low blood volume, so staying adequately hydrated can help with that. Cardiac conditions, maybe your heart's not cooperating. Vasodilation disorders, so that's usually sympathetic nervous system disorder. Extended bed rest, because when you're lying down for a long time, your body forgets how to maintain your blood pressure in an upright position. So people who are on extended bed rest are at high risk for orthostatic hypotension. And so going from lying to sitting or sitting to standing. So you always want to assess dizziness or lightheadedness during position changes, particularly after prolonged bed rest. So usually what I'll do in the hospital, I'll have someone just sit up to the edge of the bed first and say, do you feel dizzy? And if they do, then you're going to wait. You're going to make sure that they're supported and they are adequately balanced. And you're going to see how long it takes for the dizziness to resolve. And you are going to document that. So patient reports dizziness from going from supine to sitting, dizziness resolved with 30 seconds of rest. And then if it resolves faster, that's an indication that they're getting better. The next day it resolves a little bit faster. So always be careful. And then when you go from sitting to standing, do they have lightheadedness, dizziness again? Maybe they need to sit back down. Maybe they just need to stand in a supported fashion. You're supporting them while they stand until the dizziness dissipates. Maybe they need fluids. So whatever is causing hypotension needs to be determined and treated, but it's almost always the symptom of an underlying condition. There's no primary hypotension. It's usually something else that's involved. So we talked a little bit when we talked about coronary artery disease about atherosclerosis and arteriosclerosis. So arteriosclerosis is a general term that describes arterial changes that include stiffening and thickening. It occurs as a process of aging, and particularly in people who smoke or have elevated cholesterol levels. Arteriosclerosis leads to atherosclerosis and hypertension. So, atherosclerosis is a specific type of arteriosclerosis, which involves the buildup of fatty deposits or plaques inside the arteries, and it occurs in damaged vessels. So, if you recall that slide where we had the nice smooth artery and then the bumpy one, that is the damaged vessel. So, hypertension damages arteries. Smoking damages arteries. Diabetes damages everything, including arteries. In the coronary arteries, atherosclerosis leads to coronary artery disease. So these conditions just sort of creep along insidiously, and they're major contributors to cardiovascular events. So the earlier you can identify it and modify risk factors, the better off you are to avoid cardiac events. We don't want cardiac events. Really, we don't. So peripheral artery disease is sometimes it's called peripheral vascular disease. It's narrowing of the peripheral arteries. So you get inadequate blood supply and oxygen to muscles. The most common sign of peripheral artery disease, besides that ankle brachial index that I was talking about with blood pressure, is intermittent claudication, which means when you have intermittent claudication, you have pain in your leg muscles when you're walking. And it stops when you stop walking, when you rest. So it's sort of like angina for your legs, if you want to think of it that way. And you can build up your tolerance to intermittent claudication. So what you should do is have the person walk until their legs start to feel painful, and then stop and rest until the pain subsides, and then walk again until and slowly build up the time that they can walk. Other signs and symptoms include cold skin, cyanosis, ulcers, arterial and venous ulcers, but with peripheral artery disease, they're arterial ulcers, delayed wound healing, risk factors, all the usual suspects for risk factors. We're familiar with these guys by now. DVTs or deep vein thrombosis is a clot that forms in deep veins, most commonly in the lower leg. Prevention, the most important thing that you can do to prevent DVTs is to walk, to exercise. Walking is a great exercise. Ankle pumps, so dorsiflexing, plantar flexing the ankle, compression stockings, leg elevation, early mobilization after surgery is important. So when somebody has an orthopedic surgery, like a hip or knee replacement, and they're medically stable, they could have their surgery in the morning and PT's in there mobilizing them in the afternoon. So early mobilization is really important. To diagnose and treat a DVT, there are some tests that you can do in the PT clinic that might indicate that somebody has potentially has a DVT, and then you send them in for a Doppler ultrasound. The Doppler ultrasound will identify where it is. They might treat it with anticoagulants like heparin. Sometimes they put in an intravenous filter that keeps the blood clot from traveling, basically, and collects any blood clots that are in there. So DVTs can be serious if the thrombus breaks off and becomes an embolus and goes to the lungs or the heart or the brain. So it's if somebody reports sudden onset of calf pain in surgery, post-surgically, if they report that in PT, that is a good reason to send them to their doctor to get screened for that. And you want to make sure they're cleared before you do anything else with them. Aneurysms are a localized weakness of an artery, an area of an artery that bulges due to blood pressure. So the problem with aneurysms is now you have this weakened area, and if you have hypertension, it can expand, and you can actually, there can be some serious repercussions. Common locations are in the thoracic aorta. So as the aorta leaves the heart and goes down through the thoracic cavity, that's the thoracic aorta. The abdominal aorta, so an abdominal aortic aneurysm is called an 888, abdominal aortic aneurysm, um, or brain arteries. So risk factors, usual suspects, right? For cardiovascular. Early on, an aneurysm is usually asymptomatic. And if you have pressure on adjacent structures as the aneurysm grows, you might have pain associated with that, but you might not. It might just be sitting there waiting for something to happen. If an aneurysm ruptures, it can be a life-threatening emergency. You could have massive bleeding. You could have hypotension and shock. It could cause you to lose consciousness. If it's in your brain, it could cause a hemorrhagic stroke if an aneurysm bursts in your brain. So aneurysms are serious. A lot of times you don't know you have them. It might show up on imaging for something else. And that's a challenge. It's some people with connective tissue disorders, genetic connective tissue disorders, are more prone to dissecting aneurysms where the aneurysm ruptures. So if you have one of those things, you should probably be aware of that. Or if you have a patient who has one of those things. So orthostatic hypotension, we're going to do gradual position changes. So supine to sitting, and then you're going to pause 1 to 2 minutes, and you're going to time how long it takes for the dizziness or lightheadedness to resolve. Then going from sitting to standing, and then pausing for another 1 to 2 minutes. And same thing, you're going to time. You're going to monitor the patient throughout the session for dizziness or lightheadedness. And if they're symptomatic, you're going to have them sit down because you don't want someone to faint because they're dizzy. So if the patient says, I feel dizzy, sit them down or get them supine with their legs up, even better. Monitor the vital signs, ensure safety in preventing falls, and report to the supervising PT. One time I was working with a delightful gentleman who was about a foot or more taller than me. And he was in the parallel bars working on some exercises, and he said, I feel dizzy. So I looked at where the nearest place to sit down was and where we were, and I didn't think we were going to make it. So I called to one of my colleagues. They brought a chair over. I had him sit down. I had him drink water. I took his vitals. And then I slowly scooted him over till we got to the mat table, and I got him lying down. And then I put his legs up, and everything turned out well because I took precautions to prevent falls. But with someone that much taller than me walking across the distance that we had to go, I didn't think that was going to be safe. So safety is job one. During hypertension, if someone has hypertension, you want to monitor blood pressure before, during, and after exercise and be aware of the effects of their medication. A lot of the blood pressure medication cause lightheadedness or dizziness. You want to watch for exercise intolerance, and you want to avoid the Valsalva maneuver because that's only going to make your blood pressure go higher. Peripheral artery disease, you want to monitor for intermittent claudication pain, modify exercise intensity accordingly, so have them rest if they're feeling that pain. Promote walking with intolerance, meaning you walk till it starts to hurt, and then you rest until it goes away, and then you walk till it starts to hurt, and then you rest until it goes away. So you can increase the amount that you can walk by doing that. You want to do close skin inspection for ulcers or wounds because people with peripheral artery disease are prone to ulcers. Safety first. Always consider the vascular status in treatment planning. Position changes, make them gradual, especially if they've been in the hospital or skilled nursing and they've been on bed rest. Take the time to gradually transition between positions. You want to adapt exercise intensity based on the patient's vascular limitations. So with the intermittent claudication that I was just saying, as soon as they start to have symptoms, you stop and rest, and then you continue when the symptoms go away. You want to watch for signs and symptoms during activity, and any concerns, you think they might have a DVT or whatever, report concerns to the supervising PT immediately. Priority advice, you know what I'm going to say, stop smoking, most critical modifiable risk factor. Um, it's bad for you. Don't do it.